And yeah, now we move on to the next presentation, and this will introduce Christina.
Yeah, it's now up to me to present the next speaker, and this is Valentin Schäfer from Bonn in Germany, and he will extend on the role of ultrasound for diagnosis of chronic vasculitis.
Thank you very much for the nice introduction, and thanks for inviting me among this list or this panel of great experts. I have the task to talk about ultrasound for chronic vasculitis in large vessel vasculitis, and I'll try to do this within 8 minutes, those I have. We'll start with my disclosures. So first of all, Eugen, I don't know if it works. I had one question, and this was, do chronic ultrasound changes of the axillary artery in treated or old or chronic GCA exist? And this would be a question which you would like to ask the audience. Okay, very interesting. Thank you for your opinion. We'll see how it comes out. I will show you the evidence, and then we'll have a discussion in the next slide. Takayasu arteritis is, of course, also a large vessel vasculitis. I'll begin with Takayasu arteritis. As you might know, TAC produces very similar ultrasound findings as GCA. We will see a thickened vessel wall, which is commonly hyperechogenic, because Takayasu arteritis is, of course, commonly diagnosed very late. That's why if you were asking yourself, what is the halo sign called in Takayasu arteritis, it is called the macaroni sign in longitudinal section. So like the halo sign, the macaroni sign is an indicator of an inflamed vessel wall due to increased intima media thickness. Takayasu arteritis, as you might probably know, affects most commonly the left subclavian and the carotid arteries. So if you want to know, if you have a young patient who you're suspecting of having a Takayasu arteritis, you should scan the left subclavian or the carotid arteries, or add also the vertebral artery or the abdominal aorta, which we already discussed is hard to see in ultrasound. There is very little evidence on ultrasound follow-up, and of course you should look for renal arteries if the patient suffers of a newly diagnosed arterial hypertension. There is up to date just one case report on contrast ultrasound in Takayasu arteritis, which looks for wall neovascularization in contrast ultrasound in Zeus, which has not yielded into a prospective study at the moment. Going into giant cell arteritis, we finished 2 projects, and you can see the first project was published in March 2021 and the second project in May 2021. And I'll start with the first one concerning ultrasound in long-standing or chronic GCA. And the first one is concerning a cutoff value for chronic changes in long-standing giant cell arteritis of the axillary artery. And I'll start with that project. We had one group of patients with large vessel GCA and another group, a control group, consisting of non-large vessel GCA and healthy controls. They're very similar in age and also very similar in extent and time of diagnosis. If you look at this graph, you can already see that there is a difference between axillary GCA, non-axillary GCA, and the healthy controls. So we, of course, wanted to look for a cutoff value for both axillary arteries, and it yielded a cutoff value of 0.87 millimeters. By the way, we also looked at the axillary arteries over time, and we see that the axillary artery intima media thickness decreased in nearly every patient and increased in some patients again over time. We're just performing a prospective study in Bonn, which finished, and we're looking at the data of 80 patients over 12 months, and we see very similar results actually. The second project was the OMERAC project on chronic ultrasound lesions of the axillary artery in order to yield a definition like we already have for acute GCA of the temporal and of the axillary artery. And we started here with a Delphi-based web exercise, and then in the second step performed the inter-rater and intra-rater web-based reliability exercise. Beginning with the Delphi exercise, first of all, we did not perform a systematic literature review as it has been already conducted by Christina and Christian, and we extended the time and searched again, and we did not find any definition on ultrasound lesions in long-standing GCA. And below you'll find the panel of experts which participated in this really interesting and important project. So we began with the Delphi exercise. We had the first open Delphi round where we asked the experts, what would you think would be an adequate definition for long-standing chronic GCA changes in ultrasound? And then we collected all those opinions and formed 20 definitions in the second Delphi round, which then decreased to 5 definitions upon agreement. And of course, participants were also allowed to comment on the definitions. In the fourth Delphi round, we were down to only 2 definitions. And in the fifth Delphi round, we were able to present one final definition of how chronic GCA looks in ultrasound. But then many participants, many experts commented, okay, this definition is nice, but we need also a cutoff value. And by the time we had the cutoff value already published as an abstract on several congresses, so we're able to incorporate this cutoff for chronic GCA into the definition, and we performed the 6th Delphi round. So now you know why this project took nearly 4 years to finish, which incorporated this IMT cutoff value and yielded this final definition with an agreement of 91.3% in a median Likert scale, which is a scale for agreement of 5. And this is the final definition. So you have a mostly homogeneous mid to hyperechoic and very important long segmental thickening of the intima media complex above 0.9 millimeter, which is echogenic. So echogenicity often displays as several visible lines within the intima media complex. It is well delineated toward the luminal side, visible in both, of course, longitudinal transverse planes, most commonly concentric, and Doppler can help to depict stenosis, collaterals, occlusions, and of course, as it is a large vessel, atherosclerotic disease may coexist. And then we went to the second step, where Stavros Christidis helped me a lot, because first we wanted to test these definitions on images in a web-based exercise. And this web-based exercise consisted of 150 images, 50 images of acute GCA, 50 images of chronic GCA, and 50 images of normal GCA of the axillary artery. And we also incorporated for each of those 50 images, 15 images with measurements, as we incorporated, of course, also a cutoff value into the definition. And this is how it looked. So you always had the image of the artery in the upper left corner. On the right side, you had the definition of normal axillary artery, of the halo sign, and of our new definition of chronic GCA. And then you could vote, as you see below, normal, acute, chronic. And this was, of course, also repeated after a certain time to test for intra-rater reliability. And here you have some examples of how chronic GCA of the axillary artery looks. You have these several visible lines within the increased intima media complex, which of course displays as a sliding up. So this slide sign is really important. I can just emphasize what Basgar said. In acute GCA, it's more hypoechogenic, and in the normal axillary artery, you see the normal double contour line and no alteration of the intima media complex. So you see the result of the inter-rater agreement, and you see whatever we looked at, normal versus acute, normal axillary artery versus chronic, acute versus chronic, images with and without measurements, we received very good light kappa values, which constitutes our very good agreement in this exercise. And the same accounts for intra-rater agreement, so within the examiner and himself, and this was also very well, and he did very good results. So we have a new definition, and here's another picture of chronic GCA. You see intima media complex is thickened, very echogenic, or here in this patient who had been suffering about 12 months from an axillary disease. He was checked in the oncology department for many months, received repeated CT examinations, and then if you do an ultrasound of this axillary artery, you see a typical chronic old GCA. And now I just want to show you something new, which is a 3D printed ultrasound model of giant cell arteritis. And our goal is to print an artery with a modern 3D printer, the most modern 3D printer there is at the moment on the market. It uses stereolithography in order to have a gold standard for trials, and of course to teach doctors, physicians, and also medical students, why not, because we always don't have enough patients with very good disease to observe in ultrasound. So this is the printer we use in my imaging lab. And these are the arteries we designed. We first tried to extrapolate the information from MRI and ultrasound examinations, but it turned out very hard. So we designed different models of an acute GCA of the axillary artery here, a chronic GCA of the axillary artery, and a normal axillary artery. And they work very well in ultrasound. They get embedded in a specific gelatine. And of course, every artery corresponds to a real patient, which was remodeled in our ultrasound lab. And here's, for example, an example of a temporal artery. On the left side, a normal temporal artery. On the right side of an acute temporal artery. And we can print with a 3D printer structures smaller than 0.01 millimeters. So we can print tiny structures which correspond to the intima media complex, as you can see here. The arteries after printing with the structures, with the stabilization structures, and then the final artery, which then gets embedded into a specific gelatine. It's also already published, this ultrasound model. And then we can do the ultrasound. Our current model is even better. On the left side, you see normal artery. On the right side, you see a vasculitic axillary artery. And the same accounts also for temporal artery and longitudinal and transverse section. And the next thing I want to show you very fast, just because I know I have a time limit, which is POCUS. Probably you've heard POCUS. POCUS is a name for point of care ultrasound, which is coming more and more into medicine, means the doctor is doing the examination at the bedside of the patient. And in this study, we looked at, also with Christian, by the way, at a high-end ultrasound machine versus a modern handheld device, the Butterfly IQ device, which does not have a piezoelectrical crystal anymore. This is old technique. It has a chip, which is cheap in production and very high resolution. And as you can see here, we had a very high agreement of this high-end machine versus this very cheap ultrasound machine with a modern technique, which will revolutionize ultrasound imaging. And this was published in Rheumatology, and every patient was diagnosed as GCA. Of course, concordant findings were not 100%, but you can see kappa values for each artery between the two devices was very well. And I will conclude my talk. I send you many greetings from Bonn. This is my imaging working group, and the blue arrow accounts to my department, and I'm open for any questions.
Well, I have some comments. So I really like this hocus pocus. So what is POCUS standing for again?
Oh, yes, thank you. By the way, I cannot see you, but you can see me, hopefully.
We can see you.
Yeah.
Okay, because you're black to me.
It's again the bill of the electricity. It's always the same issue.
Well, I will play as I see you. POCUS stands for point of care. Now I see you again. Awesome. Point of care stands for, POCUS stands for point of care ultrasound. And this means that you're doing the diagnosis at the bedside of the patient with a small ultrasound device, which I have, of course, always with me whenever I go for a consult somewhere on the intensive care unit or whatever, wherever I go, I have it with me. It's quite cheap, actually. It's about 2,000 euros. I don't want to do advertisement, but I really like that this incorporates a chip which is performing the ultrasound and not a piezoelectric crystal. Means I can throw this against my wall and it will not break. Yes, it is very cheap in production. It can be repaired very cheaply, and the resolution is quite good. It has only 1 to 10 megahertz, but it really produces 10 megahertz. As we all know, if you have an ultrasound probe from GE or any manufacturer who says 15 megahertz, you'll never come out with 15 megahertz, because this probe produces exactly the same image, and it officially only has 10 megahertz. And this accounts for this new technique. It's called CMUT, this new ultrasound technology, which has a stable frequency of 10 hertz and reveals very nice images. Yeah.
What about the audience? Oh, there is Bhaskar who wanted to ask something.
I just wanted to really, Valentin, whether we should be extending this work to temporal arteries. For example, again, looking at all the ultrasound developments, nowadays we have such nice probes. I mean, in the temporal arteries as well, particularly you find that even after treatment, the intimal medial complex remains at a certain level, and you lose the hypoechoic nature, isoechoic, And most interestingly, you start getting this line of medial fibrosis. You know, what starts looking like 3 lines. So you have the intima and delineation from the lumen, and then
Yes.
you have the long line of the medial fibrosis.
Yes.
So you know, I've you know, maybe you should start looking at chronic changes in the temporal arteries as well.
There has been some works on Michael Schäfer on that, who was trying to state that there's atherosclerotic changes of the temporal artery, which of course we do see very, very seldomly. Really, I've seen it perhaps twice or 3 times. It's very seldom, but you are certainly right. The higher the resolution gets, and I now have the new 24 megahertz hockey stick probe from GE, suddenly really hypoechogenic, I cannot see it anymore. Yeah, of course, there's always some echogenicity, but as concerns to chronic GCA, of course, if the resolution is higher, we're able really more to differentiate between chronic and acute changes.
Now, I'm not talking about actual atherosclerosis. I'm talking about, you know, the fibrosis, the medial fibrosis, which starts coming out. It'll be interesting to get the experience of people like Wolfgang and Andreas, whether they see this sort of thing in chronic temporal arteritis.
Definitely, it's a very typical sign, and especially with these 3D ultrasound models. I'm planning to do a project, Christian and me together, to really send all experts, and of course also you, the ultrasound models embedded within gelatine, to do a reliability exercise of these models. We can do measurement, we can do the ultrasound, we can apply our ultrasound definitions. The only thing we can't do is compression sign, unfortunately, because the structures are so brittle that you cannot compress them. But otherwise, it's really a very, very fine model. We have done reliability exercises here in my clinic, and it worked very, very well. Yeah.
Great, thank you, Valentin. Are there some questions from the chat?
No,
they were simply all impressed. So I'm really looking also forward to see maybe in future that maybe all of us will have these small, tiny butterfly probes in the pocket. So you know, then you can do an ultrasound everywhere, in the bus, in the metro, and at home, wherever you want. You can scan and pick out those with the temporal arteritis. That's really fantastic.